So I have the distinct pleasure of introducing Jane, and one of the things I sent a note to Eric, and I said, okay, how should I introduce Jane? Do you have a bio, something I could read that Jane feel good about? And then he sent me a 2-sentence thing. And then I said, okay, let me get online and start reading some of her papers. And so I read a few this morning. In fact, I was just reading one when I rushed out. So I apologize for coming in right on time. I like to be 10 minutes early. You know, in the military, if you're on time, you're late. Okay, if you're not 10 minutes early, then you're on time. Okay, so I was late by 10 minutes. So I apologize for that. So, but I do want to just highlight the work that James, it is just fabulous. It's really, really top of the line. And she's really interested in really lots of issues, but bringing a lot of these issues together. Obviously, health, looking at minority and ethnic and racial issues related to health, immigration, which is just a fabulous sort of, if there's such a thing as a hobby science that I kind of engage in because I'm very interested in veterans who joined the military who are not US citizens. And if you didn't know that you could join the military and not be a US citizen, well, you can. And the way we treat those veterans is questionable. I have some issue with it. But that's not what Jane is doing, but she's looking at immigration, and that's an issue that's near to Mark. And also as it relates to HIV. And so for those of you who work with Jane, you know more about her work. I'm now becoming aware of her work, and it's really, really fascinating. So without further ado, I will stop there and Jane, take it away. And I think the goal is to talk for about 20 minutes or so,
Okay.
or less,
Or more.
or more.
Quick.
But the idea is to leave time for
Okay,
questions
I'll try
from
to
both
be quick.
online and folks in the room.
Okay,
So that's
okay.
really the goal.
No,
Thank
thank
you.
you, Carl. Yeah, I was ambitious and I'm trying to present kind of 2 studies because they were connected, but I'll try to, make it brief. But thank you for the introduction. I'm a relatively new faculty member here, so it's great to just continue to meet others and share a bit of my work. And it's been really great to hear about PhD students. I know they've been presenting in this series, so it's been great to learn about their work. And I'm also teaching the science of social work. And right now we're learning about research methods and application and really understanding how the evidence base and science informs how we engage in practice settings. So hopefully some of my students are here, but if not, I'll kind of share this recording with them. But today I'm going to be talking about language and health communication. So, one aspect of my work is related to immigration, and this study really paid attention to the issue of language and how language contributes to health disparities. And I'll be really focusing in on HIV prevention among Latino, gay, bisexual, and other men who have sex with men. So before I get started, I want you to just take a moment and think about who are the key storytellers in your life. So what do I mean by that? I mean, who are the important sources of information? Who do you communicate with and why? Especially if you're thinking about accessing health-related information, who are those key sources of information? And then take a second to think about language. How does language play a role in that? If certain sources of information aren't in the language you're comfortable in, or who do you communicate frequently with, and how does language play a role in that? And so these were some of the questions that I had started to ask myself prior to kind of engaging in the work that I'll present today. So for a brief overview, I'm going to do a really quick background, go into a little bit of the theoretical framework that guided the studies. And I wanted to present a mixed method study because we really started with a quantitative study that led into a qualitative study. But I want to be brief so we have some time to discuss. And then I'll talk about how the work and the results of the studies led to intervention development, or it's leading to basically how we can really put this into action, how we can apply some of our findings to develop interventions or programs that can address the disparities that we're seeing. So first, if many of you aren't familiar, HIV continues to be a big issue in the United States, particularly for racial ethnic minority groups and for sexual minority populations. So gay, bisexual, and other sexual minority men or men who have sex with men are the group that's most affected by HIV. And we see that among that group, Black, African American, and Hispanic Latino are disproportionately affected. So most recent data highlight that Latino MSM accounted for approximately 36% of new HIV diagnoses in 2022. And of course, one of the main factors that contribute to these disparities are social determinants of health, right? So we can think about immigration, stigma, socioeconomic status, and of course, language being another important factor. And language is really important because it's really key in our ability to obtain information about services or to learn about, disease and disease prevention. And currently in the United States, 22% of all US residents speak a language other than English at home. And among those people, majority, 62% who speak another language speak Spanish. And among people who report speaking English not very well or are categorized as limited English proficient, 81% are immigrants. So we see kind of the intersection of language, immigrant status, racial, ethnic status as well. And so this is key because we know health communication has important functions, right? So what are those important functions? They inform people about services or interventions. So think about how you know to get a flu shot or where to get a flu shot, right? You have to obtain that information somewhere. And it also motivates or empowers people to adopt specific behaviors. So, drinking water throughout the day or exercising or wearing your seatbelt when you get into a car. And also builds connections, right? It builds social connections based on the behaviors that we might engage in, whether it's, through activities or sports. And it can also create enabling environments, right? So if there's parks or areas to play sports in, or if there's availability of fresh food. So all of these factors are part of health communication and what informs us in kind of the behaviors and actions that we take. And that's why health communication is so important. And in thinking about health communication, I drew upon communication infrastructure theory, which really draws upon that health communication framework. And health communication infrastructure theory was actually developed by Sandra Ball-Roquette, who's actually from USC's Annenberg School of Communication and Journalism. Many years ago, she developed this theoretical framework as a way to understand communication in multicultural and diverse settings. And really the key foundation of CIT is that there is the storytellers who are the main actors who have the capacity to tell stories about a community, a city, a nation, or even the world. So these are those sources of important information. And then there's the communication action content, which are features of the environment or context in which you are in, which can include, cultural, economic, physical factors that can constrain or facilitate those storytellers, right? Those micro level, meso level, or macro level storytellers and sources of information. And what's really key about CIT is it, in this theory and in this application of the theory, H.A. Wilkin, which is a CIT scholar, really emphasizes that there's not one communication strategy that works for reaching everyone, especially when you consider the interaction of race and ethnicity and place. And I also argue with my work, thinking about language as well. And so this is a kind of a complicated little framework, but this is what guided my work. And, in a straightforward way, it's the communication action context and the storytelling network. So it's the communication infrastructure that I just mentioned. And it's embedded with a common behavioral model, the information, motivation, behavioral skills model. The idea is thinking about how that communication infrastructure shapes those, proximal determinants of behavior to shape the outcomes that we're interested in. So I was interested in those HIV prevention outcomes, HIV testing, PrEP uptake, and thinking about how the communication infrastructure shapes access, information, motivation, behavioral skills that can all contribute to those HIV prevention outcomes. And so my first step in really thinking about this communication infrastructure theory in relation to HIV prevention outcomes among Latino MSM was to look at it quantitatively. So we first used a secondary data set, which is the American Men's Internet Survey, which is an annual cross-sectional survey of men who have sex with men. And they seek to collect data from approximately 10,000 people every year. And I used data from the 2021 cycle, which is actually the year that I helped launch releasing the survey in Spanish as well. So they collected data from participants in Spanish, which allowed us to do this analysis. And I wanted to really focus on the differences in understanding those key storytellers and aspects of their communication action context by language. So whether they reported their primary language was Spanish versus English. And so briefly, these are some of the measures that we looked at. And so we had the HIV related outcomes, which were, HIV testing and PrEP use. But we looked at storytellers, and the way that we assessed storytellers was through a question that asked whether participants had disclosed their sexual orientation to friends who identified as gay, lesbian, or bisexual, non-gay, lesbian, bisexual friends, family members, and healthcare providers. And our idea was that if they disclosed their sexual orientation to these groups, then they might serve as potential storytellers or sources of information related to sexual health and HIV prevention. And then the meso-level storytellers, or those meso-level sources of information, were assessed through a question that asked whether they participated in church activities, cultural activities, and activities in the community. So again, these are kind of three potential sources of information. And then the communication action context was assessed by census region, so whether they lived on the west, the south, the northeast, or the northwest. And then the urban-rural classification of county of residence. So the census classifies counties based on the population size. So it could be a large metro, a small metro, or kind of a small rural area. And then of course, we looked at sociodemographic characteristics and then language based on whether they reported preferring Spanish versus English. So I'll kind of highlight the main points of our analysis, but we did analyses to assess the associations between those storytellers and the HIV prevention outcomes by language. And we conducted separate models. So we analyzed it separately for those who reported speaking Spanish versus English. And that was to really assess those different storytelling networks of the two groups. And these are just some select sociodemographic characteristics of the participants. There were a total of 849 Latino MSM in the AMIS sample, 554 who reported English speaking, and then 285 that spoke Spanish. And overall, in the sociodemographic characteristics, we just saw that, the Spanish-speaking participants had lower incomes overall, tended to have lower levels of education. They were less likely to report having insurance, and were also less likely to report being born in the United States. And they were a little older on average as well. And in looking at some of the main outcomes, I think what's key here is that for the English-speaking Latino MSM, overall, they were more likely to report engaging in the HIV prevention behavior. So were more likely to have tested for HIV, have used PrEP and be aware of PrEP than the Spanish-speaking Latino MSM. And they also were more likely to report having some of those storytellers accessible. So more likely to have reported disclosing their sexual orientation to those key groups and report participating in activities than the Spanish-speaking participants. And for the English-speaking participants, disclosing to a healthcare provider was associated with greater likelihood of STI testing, and also residing in a medium-sized metro was associated with lower likelihood of STI testing versus a large-sized metro city. And I think what's key about this is just indicating that healthcare providers emerged as a potential important storyteller, and then recognizing urbanicity and location as important factors of that communication action. And again, disclosing to a provider was also associated with prep use for the English-speaking participants. And for the Spanish-speaking participants, there were less kind of significant associations between the storytellers and the communication action context variable, but disclosure to a healthcare provider was associated with a higher likelihood of having used PrEP in the last 12 months. So again, really demonstrating that, okay, healthcare providers were a potential key storyteller for this group. And overall, I think the main findings from these quantitative analyses was that first, the Spanish-speaking Latino MSM experienced these structural disadvantages, right? So they were less likely to have health insurance, lower levels of education, lower incomes, and then they were also less likely to report the individual and meso-level storytellers that we were able to assess in that data set. And so while we learned that, it is important to assess these potential sources of information, we wanted to learn more about who those key storytellers were for the Spanish-speaking Latino MSM and better explore that in relation to sexual health and HIV prevention. And so that's what led us to the qualitative part of our study, where we wanted to conduct in-depth interviews with the Spanish-speaking Latino MSM to really understand who the important sources of information were and kind of determine the strengths and limitations of their storytelling networks. So we actually recruited these participants from that AMOS listserv. We emailed all the participants that reported speaking Spanish as their primary language, and we conducted interviews via Zoom and both. And so our qualitative analysis, we took a very detailed approach, a 5-step approach, where we developed a code book based on communication infrastructure theory so that we could really understand key facets of their storytelling networks as well as their communication action context. And we coded the transcripts with 2 coders in Deduce, and we obtained, very detailed reports from Deduce to identify the core themes that emerged from those interviews. And so these are just some select characteristics of the participants in terms of age. They were on average 38.7 years old, most identified as gay, with 3 identifying as homosexual. Interestingly, half were born in Colombia and 7 from Mexico, and I think that was just the nature of who responded to the call for participating. There was an average of 8 years living in the US, and participants lived across 10 different states, including Florida, New York, Washington, Texas, and California. And overall, there were reports of engaging in behaviors that could increase risk for HIV. There was an average of 7.8 male sex partners in the past 6 months, and differences in terms of HIV testing history and abuse. Okay, so I wanted to get into the main theme. So one of the primary themes that emerged was, of course, many of the participants talked about how language was a really big barrier to accessing health services and HIV-related services. They talked about, even being embarrassed to try and seek services, or when they engaged with a provider that didn't speak Spanish, how they felt humiliated a lot of the times, which could deter them from seeking services later on. But they also noted how important it was to feel connected to their neighborhoods. And many of them talked about living in a quote unquote Latino neighborhood where there were a lot of other people who spoke Spanish or who identified as Latino, and how that helped them really feel connected and also be aware of relevant sources of information, as well as aware of services that are available. And so in this quote, someone said, to find a space where there are people who have the same diagnosis as you, and you can all live together, generate certain friendships, share spaces. It's very cool because obviously, even though everyone is different, there are certain particularities we share. We are all Latinos, we all speak Spanish, we all arrived at some point as migrants, we all have the same diagnosis. So let's say that this affinity allows us to relate to each other. And so this participant was actually talking about how it was really, really important for them to have other Latinos, other people who identified as gay, bisexual, or MSM in their community, and how that served as a really important source of information that they were able to trust with. And really key was the presence of community-based organizations. So having community-based organizations that really catered to the Latino community was really key in feeling connected and having um, an important source of information. And also they talked about the importance of their interpersonal social support networks. But interestingly, they highlighted that they have support networks, but not everyone is a key storyteller. So a main point that came from this was many of them talked about how they were very close to their family and they had lots of friends and cousins, but those people weren't necessarily the sources of information that they went to specifically for sexual health or HIV related information. And they talked about having peers as really vital to having an important source of information for sexual health. So this quote really exemplifies that. Participant said, "The most important people to me are really my parents, my sister with whom I have the closest relationship, and 2 or 3 friends. That's my close circle. But when it comes to topics related to HIV, my mom, my dad, and none of them know about this. Why don't they know? First, because it's very difficult. It was very difficult to tell them I was gay, especially with my mom. And now tell her, hey, then I would literally be the gay black sheep with HIV. And that would be much more complicated. Besides, they're older people. I don't want to say that they wouldn't understand, but I've tried to keep it separate so they don't stress out." So again, it was really highlighting the different sources of information for different purposes. And many of them also actually pointed out the dual role of healthcare providers, because in that quantitative study, we assessed healthcare providers as a potential important source of information. But in the qualitative portion of the study, many of them said, yes, healthcare providers are important and they are important and trustworthy sources of information, but they're not always accessible to us because of the reasons that I previously mentioned, because of the language barriers, because of not having health insurance, or not really having people who identified as them in the community. And so there was this kind of complex role in the sense of healthcare providers being potential sources of information, but not necessarily being accessible for the community. And then finally, another theme that really emerged in the qualitative interviews was the importance of social media and the internet. They talked about how, it's become such a common communication channel and how many of them use social media so frequently that it became a very, very kind of important source of information. But they also did note that not everything that they find on the internet or not everyone that they kind of engage with on the internet are trustworthy sources of information for HIV related information, and how they preferred that type of information came from, community-based organizations that they trusted or from nationally recognized organizations that they were familiar with. So again, having that trust was really key. And so what kind of came together from that quantitative and qualitative study was, of course, that language matters. It's really key for health communication, and we see that it can shape distinct behaviors and outcomes for communities. And what was also important was that multi-level aspect of understanding sources of information, because there are those individual level sources, but also the importance of recognizing the context in which organizations or people are embedded. And so really thinking about that and thinking how the different levels intersect to shape HIV and health related behavior. And then finally, it really pointed to the importance of e-health and technology. So I've done a lot of work that's explored social media and the use of e-health related interventions. And I think it really underscored the value of that and the potential ways we can harness that, especially for this population. And so kind of taking this all together, I've kind of tried to bring, I know this is a little complex, but I'll kind of go through this, but I wanted to take what we learned from both the quantitative and qualitative study and think about how we could apply those findings in terms of kind of putting things into action. So how can we develop interventions from what we learned from those, the qualitative interviews as well as the quantitative study. And that's led me to kind of think about an integrated model where we kind of think about the communication infrastructure or the storytelling network as well as the communication action context. And then again, thinking about those proximal determinants or those factors that can shape behavior. So that's the IMB model here. And then how we can kind of apply that in thinking about how to influence HIV prevention clinical outcomes. And so what we did is we learned that peers were really key. So we're thinking about how can we train the capacity of peers to be able to connect Latino MSM to the CBOs that they trust and want to kind of receive services from. And so what we did was we developed this peer training, and it was an online training. So again, we drew from the findings from the study where, we could really utilize online training resources to build capacity, especially for peers or community health workers. And so we, in a different study, we basically trained peers through an online training that we developed in partnership with a community-based organization. And what we want to do is think about how we could use those peers who are trained and help link other Latino MSM to community-based organizations that provide HIV prevention services in culturally relevant ways. And so we're kind of thinking about implementing an overall peer-led communication linkage intervention that applies the health communication model as well as the IMB model in shaping HIV outcomes. So I hope I kind of explained that in a clear way, but we're really harnessing the peers that were identified as key storytellers as well as the CBOs and using the social media and technology as a way to train potential peers that can do outreach to Latino MSM to ultimately address the disparities that we kind of started with, right? The problem that we identified and how we can improve HIV prevention outcomes. So that was my mixed methods study. I want to thank all my community partners, co-authors that I worked with at the University of Washington, as well as Emory University. This was from two publications from a grant funded by the University of Washington Fred Hutch Center for AIDS Research. And of course, acknowledge the funding from the American Men's Internet Survey that conducted the quantitative data collection. So thank you. I let do that because I wanted some time for questions. So yeah, any questions or anything that.
I just want to make a great, that figure, that last one is fantastic.
Oh,
right?
great.
That is a great,
That's
great
going into
figure.
my grant application. So.
So that is a great figure. Thank you. Any questions online in person?
Yeah.
I'm just curious, I'm not sure if you were involved in interviewing the participants, but just in general. Not like identifying with the community that you're working with, what sort of like strategies or just your approach?
Yeah, I think that's such an important question. I could talk about that a lot. Just in my community engaged work, I don't identify as Latino or gay, bisexual, or MSM. So recognizing that, and then I'm not, Spanish is also not my native language. But I think in my work, and I could talk a lot about community-based participatory research. I really center the community and have them really lead the work and really work in partnership, which I think allows the work to be so fulfilling as well as effective. And so I didn't conduct the interviews. I had Spanish-speaking individuals who are native born speakers do the interviews, but it was all actually analyzed in Spanish and all the codes were in Spanish. And then it's only for kind of the publications and the reports where we translated it. But I think that's really important in terms of building rapport for doing some of the interviews. But I've also done qualitative interviews in Spanish and with community members that I don't necessarily identify with fully. And I think it is thinking about that and being intentional about how we approach and how we engage. And what's been helpful is that I do partner with community organizations. And so, by building that trust with community partners, the participants also know that I'm working with those community partners, so there's trust that's built in that. And then it's a lot of relationship building. I think even with participants, when you're conducting studies, like really being intentional and recognizing the goal of the work that you're doing. Of course, human subjects protections and all of that is really key, but again, I always come back to really centering the community first, and so that's helped in that process.
Hey, Gene, this was a great talk. I so many points of intersection with some of the work that I've been doing recently with a very different population. But I think, I was interested in the slide before this slide where you were talking about the qualitative interviews and you were highlighting a lot of things that had to do with language, but then different sorts of communication. But then when you moved into the slide that Carl loves, which I also love, I really was happy to see that you were centering so much of this action of the storytellers and the different sorts of storytellers. I think you know I yeah, I was just working on a paper with some former PhD students that's looking at who is it that youth experiencing homelessness talk to about HIV testing, PrEP, these sorts of, very similar sorts of issues. And we're doing a social network analysis. And like you found, it was the people who they have these trusting relationships with that kept coming up in our quantitative data. And so I'm really excited to see that you are working on leveraging those insights into your intervention work. I guess maybe one question I have for you is, what is the intervention that you are building out? What's it going to look like? Who are you going to deploy it with? What stage of development are you in with that? You kind of alluded to it a little bit at the end, but I'd love to hear a little more.
Yeah, no, that's a great question. That could be like 3 other studies that I tried
Oh,
to
I'm sure.
so many, but so there was one study where we worked on really developing the training itself for the peers. So it was really based on, evidence-based modules of and based on the IMB model of can we like provide peers with information, how can we help motivate them, how can we give them the behavioral skills to engage other Latino MSM. So we did a whole study where it was an iterative process. We worked with 7 different community-based organizations to develop the training. We piloted it, and then we tested it, and we tested it with 10 peers who took the training. And it's all asynchronous, actually. It's like 5 modules, and they learn about HIV testing, PrEP, adherence, and what it means to be a peer, and also like self-care kind of skills. And so this overall intervention is kind of thinking about it in terms of, okay, so we train the peers. Now, how do they kind of function, right? They need to be embedded or work with a community-based organization, but sometimes the processes in doing that isn't really clear. And so our intervention has implementation strategies, if that makes sense. So if you think about, somebody develops an intervention or a program, that's great. They test it and it might be effective, but what does that mean for kind of organizations that want to deliver the program or deliver the intervention? And sometimes it can really be stuck to kind of the study or the quote unquote science of like testing it. But in the real world, sometimes it might not be sustainable, or you might not be able to maintain that program outside of the study. And so this is kind of more of an implementation strategy as well as intervention, where we're testing the training of the peers and then seeing what additional strategies we need to help embed them in different community-based organizations. So we're actually going to work with a community-based organization in Los Angeles, as well as Seattle and then North Carolina, to see what other supports do we need to help the peers be successful. So it's kind of thinking about peers, because they were this important source of information. How can we train them? And then how can we make sure that they're actually able to reach people and then bring them to the community-based organizations that are providing?
No, that's really cool. And I think, at least in my work where I've done peer-led interventions like this, it can oftentimes be very hard to measure the impact that those peers have in their communities. And so we don't have to take up more of your time here, but I'd love to chat with you at some point about how you're planning on measuring those effects, because that's a challenge as well as just giving it, the communities these interventions to use afterwards. And I really applaud you for thinking about how to make this something sustainable after you and your research, monies and infrastructure leave. I think that's a really important part of this kind of work. So thanks so much.
Curious about, it seems like the two groups that really stood out in terms of like this kind of communication and support were the peers and then healthcare providers. I'm curious if there was any discussion of like how healthcare providers like stigma or support was impactful to the individuals in either group, either the predominantly like English speaking or Spanish speaking groups, because at least in the qualitative experiences, it seems like there at least was this report that like language was a barrier, but I wonder if there was additional barriers in terms of feeling judged or understood by their providers.
Yeah, so you could find, there's some quotes in the qualitative study that I did, and I think that's a great point because many of the participants acknowledged feeling like judged or stigmatized. I remember one quote of somebody saying that they went to a provider seeking HIV prevention services, and I think they were in a state that, was less kind of accepting of people who identify as gay or bisexual. And so they talked about this horrible experience where they were like refused to prescribe them PrEP. So I think it is like thinking about, not only the identity of the provider, but also the context and policies that exist in the context or state in which people are living. And so that's why, while providers did emerge as this, of course we all trust doctors or healthcare providers, what was really key is that community-based organization. And when people are referred to providers through a trusting CBO, they're often linked to providers that provide services in the language that they want, or, are more familiar with like cultural norms or social norms. And so that was what really stood out, even though, people did mention that, we want to go to a doctor, and many times they have to see a doctor for a lot of these services. So it was this really nuanced perspective that emerged. And I think it was less so for the English speaking and the quantitative because, they factors such as acculturation or being able to speak English, and there might be less barriers in terms of interacting with the provider.
Jane, can I ask so in reading some of your papers, and of course I read your papers through, I know you're focusing on communication, but I read them through the lens of overcoming stigma. And it struck me reading your papers, and again today in your presentation, that there are lots of stigma in place, right? There's the stigma of sexual orientation. There's the stigma of HIV. There could even be the stigma of being an immigrant.
Right.
There could be stigma of even, and you didn't talk about this, but having a mental health issue. And the military spends a lot of time working on overcoming stigma, but they do it in a clunky way. It's like, don't be stigmatizing and don't be ashamed of your stigma. Basically, that's the technique, the training technique that the military uses. But this is a very, very different approach. And it's an intervention that overcomes all of these stigmas kind of in one go. And how would you respond to someone saying this is an intervention now, how to overcome multiple types of stigma, but it's one intervention. It's not an intervention for this, an intervention for that, an intervention. It's one intervention that overcomes all of these stigmas at one time, which I just find amazing.
Yeah, no, I think that's a great point. And I do a lot of work in thinking about intersectional stigma, right? And oftentimes we can't even disentangle those stigmas because they're so tied to each other. So in essence, you really do have to address all of them. You can't try to say, okay, I'm just gonna address this one stigma because oftentimes they are so interconnected. And I think, and this is where kind of social work is so key when we think about like humans in their environment, when you think about like individual level behaviors and perspectives, but also the context in which they're living and how you can't really, take the individual out of the environment. Similarly, you have to address the person, but also in their environment and in the communities that make sense. And so I think just thinking about that in that way leads you to develop interventions that can be more holistic and address all aspects. Because, if you just provide services or if you, tell somebody something, if they can't do anything with it, then it's not going to lead to anything. So that is what is so exciting about like thinking about things theoretically, bringing in multiple perspectives and disciplines, and also like recognizing the full person of the communities that we're working with so that you take a more holistic approach. And I think that leads to more sustainable outcomes. And really with this project, it's a lot of implementation research too, which really asks you to think about that. And so you can't just say, I'm gonna develop this program and that will fix this one issue if it's connected to so many other issues. That makes sense. So thinking about all the
I
obstacles.
just found it fascinating.
Yeah.
Hi, Jane, how
How
are you?
Good.
I'm wondering, this group, at least in your focus group, the issue that they are challenged by stigma is probably an ongoing everyday situation, right? Lived experience. And I can see how they would complain about their providers, for the treatment that they get or inadequate or just, biased treatment. But one thing that I know about this group is that they do not either understand or have not been given the information or for personal reasons, do not access what they can do about it. So if the individual provider treats them in a way that's disrespectful, et cetera, there are channels to complain, to put in a formal complaint. I don't think that's available to them. They don't know that that's available to them. Or if they do, they don't think they can enact it. So we were talking about social learning theory, social cognitive theory today in our class. They haven't seen the models that have said, you know what, if you do experience this type of horrendous behavior in your medical encounter, you could do something about it. You could write a formal complaint. They have no idea about that. And if they're immigrants, less of an idea about that. So this would be something in the peer training that would be very important, is what redress do they have when they encounter these horrific encounters with their medical providers.
Yeah, I think that's such an important point, especially because they start to kind of have this history of experience and that continues to shape future behavior. So having peers, oftentimes a lot of the information that you are able to find are from others in your community. And so if you learn that, oh, you actually can do this, or this is who you need to talk to, or this is another place you can go to, then that can really empower them and shape future behavior. So I do think
Or I can go with you to levy that complaint. I can help you write the complaint. So it empowers the individual to do something about it for themselves and for others, that they can, an altruistic motive as well.
And that's why information, like having that information is so important, and why don't people know that they can complain, right? It is a lot of the barriers that they face. So really making that information accessible, and then once they have it and are aware, then they can actually apply it. And that's like the whole thing with HIV too. A lot of them they don't think that they can get tested, or they're afraid of what will happen. But once they learn, oh, you can go here and this is a place you could go, and they could give you additional resources and support, then you might be more likely to kind of go in that direction.
Jane, are the providers the same sex?
Not necessarily,
Do
but
you ask that question, like, what sex is the provider?
when in like the interviews, when they talk about
Well, no, in the quantitative,
Oh, no, it was just a healthcare provider, like.
Okay, so you,
So we didn't ask like.
okay,
what
I was
the
just
gender-
curious is
Yeah.
if there was a difference based on provider characteristics.
Yeah,
One of the things I literally just discovered 3 years ago is around chaperones. That I didn't realize that even if it's the same sex provider, I can still have a chaperone. I thought you could only have one if it was a different sex provider. Am I the only one that didn't know that? I mean, I literally learned that. And so I always think a chaperone is always, could be a good thing. Because people behave differently when somebody else is there with you as a patient, like if I'm there as a patient. But I just realized that, and not because I realized, somebody asked me, do you want a chaperone? I said, well, isn't this a male provider? They go, yeah, but you can still have a chaperone. I did not, it never would have occurred to me in a million years to have a chaperone in that situation.
I think it's like having an advocate, right? And you
Yeah,
can always have an
I think
advocate.
the chaperone asks an advocate, you know,
Yeah.
am I saying the right thing? Am I communicating effectively? Are they hearing what I'm saying?
Yeah.
And so anyway, as opposed to going straight to the complaint way, which is actually a response to a bad outcome, bring in a chaperone to prevent the bad outcome from happening to begin with. So I don't know, I'm just
No,
throwing out
that's
ideas.
like the peers, you know, they're kind of like peer navigators.
Yeah,
peer support,
exactly.
so, yeah.
But I like the complaint thing, but I don't know, do they have paper and pencil complaints anymore? All the ones I get are electronic.
Pencil, what's a pencil?
Well, then plus you have to write it,
Yeah.
right? And if language is a barrier, then that would. Oh, well, this is. a
Chrysler
different-
has it, both electronic.
Oh, they do have both?
Yeah,
Yeah.
because I'm putting in a complaint and they said I could do it either.
Well, thank you all. I know we're at 9, so happy to connect with any of you.
Oh,
who are
Great job,
interested
great
in,
job.
um,
Thanks so much, Jane. It was great to have
Another
you.
round
in
of
my
applause.
series.